Great. Hi, everyone. Welcome back to Health Healthcare. We are switching gears and we're going to H766. And we're reviewing section 1, which is the last section to cover with testimony at this point. There'll be more testimony coming forward, I'm sure. And so I've asked Jen to do, we walked through section 1, but it was a while ago. So I'm going to ask Jen to do a walkthrough of just section 1. Jen, no need to put it on the screen. I think everyone has it in front of them. And then we'll go to our witnesses. So thank you, Jen.
Sure. So for the record, Jennifer Carby, Office of Legislative Counsel. So I will not put the language up, but I will put it up in front of me. So the language in section 1, and we're looking at H766, would amend a provision of Title 8 in the health insurance statutes. It's an existing section on prescription drug benefits in health insurance plans. And there is an existing section that prohibits a health insurance or other health benefit plan offered by a health insurer or pharmacy benefit manager on behalf of a health insurer that provides coverage for prescription drugs. So we're talking about a health plan that covers prescription drugs and uses step therapy protocols. Under existing law, the plan cannot require failure on the same medication on more than one occasion for continuously enrolled members or subscribers. And then there are a few other provisions. The bill would significantly expand that. So first, it would prohibit requiring failure, including under that definition of failure, discontinuation due to lack of efficacy or effectiveness, diminished effect, or an adverse event on the same medication on more than one occasion. And then it's specific to insureds who are continuously enrolled in a plan offered by the insurer or its PBM, pharmacy benefit manager. So can't require failure for the same medication if the insured continues to be insured on a plan offered by the same insurer. And a plan must grant an exception to its step therapy protocols upon request of the insured or the insured's treating healthcare provider under the same time parameters in place for prior authorization if any one or more of the following conditions apply. So if the prescription drug required under the step therapy protocol is contraindicated, or it's likely to cause an adverse reaction or physical or mental harm to the insured, if the prescription drug required under the step therapy protocol is expected to be ineffective based on the insured's known clinical history, condition, and prescription drug regimen, if the insured has already tried the prescription drugs on the protocol or other drugs in the same pharmacologic class or with the same mechanism of action, and they've been discontinued because of lack of efficacy or effectiveness, diminished effect, or an adverse event, regardless of which plan, whether the insured was covered on a plan at the time offered by the current insurer or its PBM. If the insured is stable on a prescription drug selected by the healthcare professional for the medical condition under consideration, so if they're already taking a drug that they're stable on, or if the step therapy protocol or a prescription drug required under it is not in the patient's best interests because it will pose a barrier to adherence, so for some reason it makes it less likely that they'll keep taking it the way they're supposed to, or would likely worsen a comorbid condition, or is likely to decrease the insured's ability to achieve or maintain reasonable functional ability. And then the other provisions are really unchanged from existing law, allowing for tiered co-payments and having a specific additional provision related to treatment of substance use disorder.
Thank you, Jen.
Sure.
So this is, any questions for Jen on the language, and we'll get much more understanding of what this means with our witnesses that are coming up. Okay. Great. Thank you, Jen.
You looked at me like I might have questions.
I just haven't looked that way. You don't. Nancy. You there, Nancy?
Yep, I am trying to get my video on.
Take your time. So Nancy's joining us with Blue Cross Blue Shield. She's the pharmacy director. And then later on, we'll have Ann Morris join us. Ah, there she is. Good to see you.
Good to see you as well. Thank you. The lighting isn't great here, but hopefully you can hear me all right.
Yes, we can. Thank you. So we just had the walkthrough. If you want to introduce yourself for the record and then provide your testimony and be prepared, because I think we'll have a lot of questions just on what this is. So turn it over to you.
I'd be happy to. So for the record, my name is Nancy Hogue. I'm a pharmacist and I'm the pharmacy director for Blue Cross Blue Shield Vermont. I've been with Blue Cross almost 2 years, and the 12 years prior to that, I was the pharmacy director for Vermont Medicaid. So I worked for DEVA for the 12 years prior. So I've been a pharmacist in Vermont for about 27 years altogether.
Great. So did you have prepared testimony you wanted to start with?
Yes, I do have a
Okay.
couple of slides.
Great.
Let me go ahead and get those pulled up. Just give me a second to screen share here. Okay, are you able to see my slides?
Yes.
Okay, that's great. Alrighty, so I thought I would just start by kind of level setting and giving you just some basic information on our drug costs. And
I'm sorry, Nancy, I'm sorry to interrupt. Can you put it on presentation mode?
Yes.
Don't ask me how to do that.
Yep, I can do that. Just a second. Okay.
Great. Perfect. Thank you.
All right. So I just wanted to level set and give you a little information, high level information on our drug costs at Blue Cross and some of the trends that we're seeing in the last year. So I put 2022 and compared that to 2023. I won't go through this entire chart, but I want to highlight that our total drug costs have increased almost 25% in 1 year. So there is a significant increase in overall drug costs, and that is being driven by a couple of factors. One is that we just have an increase in the number of prescriptions, the number of drugs that people need to take for their chronic conditions is ever increasing. And so that's driving about 8.6% of that trend. And then the average drug cost per prescription, so the actual cost of drugs, is going up as well. And so when we look at all drugs, we're seeing about a 15% increase per prescription. And that varies whether it's a specialty drug or a non-specialty drug. As you know, specialty drugs are far more expensive than traditional drugs. The average cost of a specialty drug is about $8,000 per prescription, and the average cost of a traditional drug or a non-specialty drug is only about $112. So there is a huge difference when we consider specialty drugs, and because of that factor, specialty spending is over half of our drug cost, but only represents less than 2% of our prescription volume. So that's something to recognize when we're talking about some of the utilization management, including step therapy and PAs.
Okay, Nancy, we're going to stop you there. We just have a couple of clarifying questions. Leslie?
Yeah, my clarification is just that, is this per month or per year?
This is
When
for-
you're talking about average drug costs?
that's for 1 year.
1 year, thank you.
And can you just give a couple of examples of a specialty drug?
Sure, they can range from like a lot of oncology drugs or specialty drugs, a lot of the drugs that are used for as anti-inflammatories. So if you have like Humira is a good kind of example that everyone recognizes, drugs that are used for psoriasis, psoriatic arthritis, rheumatoid arthritis, those are considered specialty drugs. So they're generally drugs that are not only high cost, but also they're often injectable, not always, but often they're injectable. And they also can have some additional like safety considerations, need to be perhaps more closely monitored. So there's not really a formal national definition of a specialty drug, but that's probably a good overview.
Okay, great, thank you. Brian?
I'm curious.
Okay.
Hold on one second, Nancy. Go ahead, Brian.
I'm curious.
Thank you.
Can I just ask you like the questions up front, and then you can answer them in whatever order makes sense?
Sure.
I'm curious why the prices are going up so much. I'm curious how this looks over the last 10 years, not just year. Like, is this like, are these numbers what we see every year, or is there a spike? And there was a third question I can't remember, but when I remember it, I'll ask.
Okay. I guess I'll start with the trend. I don't obviously have 10 years of trend with me, but I will say like the last several years, generally the last 10 years, we have seen a trend every year, an increasing trend every year. Okay. The level of that varies by year. And of course, with COVID, that kind of skewed some of the spend numbers because we had COVID vaccines, and that represented a more impactful phenomenon. So COVID, when you're talking about COVID years like 20 and 21, you have to consider COVID vaccines, and oftentimes when we present data, we back out the vaccines to kind of take that out of the equation, if you will, so it's a little more comparative. But in general, drug costs have just been increasing every year, and more particularly, launch prices of drugs have been increasing. So, specialty drugs in particular, we used to think $10,000 a year was a lot for a specialty drug for a launch price, but now like routinely launch prices on specialty drugs are $50,000 or $100,000. So I would say that is one of the biggest problems, is that new drugs that are coming on the market have very high launch prices. And that's contributing a lot to the increase in spend.
Great, thank you, Nancy. We might have more questions for you later, but I want to get to the step therapy part.
I have a question about this slide.
Go ahead, Mari.
A few questions, actually. What is the source for your information? Is this just Blue Cross Blue Shield Vermont that you're talking about? And what costs are you referring to? Are you talking about the wholesale acquisition cost, the actual acquisition cost, the amount the PBM pays the pharmacy?
So Mari,
Mari,
I'm going to stop you. So we can come back to this, but I want to get to the bill, which is about step therapy, not technically drug costs. So I promise we will come back to this, especially because we have testimony on PBMs coming up. So if you can write down your questions, we have limited time. And we'll either send Nancy your questions, or we'll have Nancy come back when we talk about drug costs.
I think the drug cost is actually a quick answer.
Okay, I'm going to ask that we stop this right now, and we're going to continue on with step therapy. Thank you. All right, Nancy.
Okay, so I don't, probably a lot of you have seen this chart before. It's really just an overview of the drug distribution system in the US. The reason I'm showing it is I'm certainly not going to go over all of the details in the slide, but I'm really using it to illustrate that in the upper right-hand corner is the third-party payer. So that is Blue Cross, that is Medicaid, that is, everyone who's paying for the drugs. And we have influence over a very small part of this drug distribution system. So we don't control how manufacturers price their drugs. We don't control what wholesalers charge for drugs. We don't control what pharmacies pay for drugs. So it's really just to illustrate that small part in the upper right-hand corner. We have a limited ability to control costs in the entire system of in the entire process of drug distribution in the US. So that was my kind of the point of this slide that I'm trying to illustrate.
Okay, Art, hold on, Nancy, Art, do you have
I have
a
a very
question?
quick question for you. Could you by chance take that slide and send it to us as a separate photo, picture?
I can do that.
Yes. Yes, we can do that. Thank
Oh,
you.
all right.
Printed, yeah.
I mean, I would love to have that.
Yeah, thank you. Okay, Nancy.
Absolutely, yep.
And
This is, so I want to stress how important drug utilization management is to the health plan. And so I'm going to report some savings that are attributable to the various UM programs that we have. The most important of those is prior authorization. I have more data. If you want, I know this isn't, you don't want to hear about PA today, but I do have some slides on that if you'd like to hear more later.
Okay.
However, we do have a large millions of dollars in savings attributable to that. Quantity limits also contribute a large savings, and step therapy, while not the largest savings, it does have a contribution of about $3.28 per member per month in savings. Altogether, these utilization management programs are saving almost $39 million a year. So they're very, very important to us in controlling net costs, and of course, whatever trickles down to premiums, of course.
Great, thank you. Yeah, so I think we're gonna skip the prior, they're in here, but we're gonna skip the prior auth since we've agreed that's being handled right now by a small subcommittee. So Nancy, if I guess we're on slide 10.
I reordered them because I heard your comments that you weren't going to do step therapy. So, I mean, prior authorization.
Okay,
I
perfect.
just reordered the slides a little bit.
Okay, I think we still have the old one, so if we can go to slide 10. Great, thank you, Nancy.
So in terms of step therapy, I wanted to comment on, and I did put the page number and lines in here just so you can track the paragraph that I'm speaking to. But this one essentially says that we should allow a bypass of step therapy if the insured has tried the drug on the protocol, which makes sense. But then it says, or other prescription drugs in the same pharmacologic class or with the same mechanism of action. And I just want to point out that that isn't just because a drug is in the same class doesn't mean that it won't necessarily be effective for an individual. So efficacy can be very patient specific. In many cases, patients will respond to one drug in the class, but not another. So I think it makes sense if that clause could be removed. Just to give you an example of this, probably one of the better examples would be the migraine medicine, some of the triptans. There's 9 or 10 different drugs in that class. And physicians will often try different drugs in that class, depending on how the patient responds. And patients don't have the same response to every one of those drugs. So that's kind of my comment there. And then further in that paragraph, it says, regardless of whether the insured was covered at the time on the plan offered by the current insurer or its PBM. And for this one, I would just say that, you know, we think it's reasonable to expect reasonable evidence of a trial, not just, you know, anecdotal information or, you know, oftentimes if it's self-reported by a patient, it may or may not be 100% understood, you know, especially if they don't have a good understanding of their treatment. So we just would like to remove that clause because getting information, for us to get information from other providers or other health plans where they were insured previously, that's not really something we do today. And that would certainly require process system development, or there would have to be a different process in place if we were to have to obtain that information from another payer. So I think it'd be very helpful if that particular clause could be removed.
So just the regardless of section, you're comfortable with the language before that?
Yeah.
Okay.
And the reason for that is because you don't want it to have to go to another insurance company to get that information. Is that my understanding? I just wanted to, if you could just restate, if you don't mind, I'm just trying to understand, you don't want to have to do that because there's no process to get that information from another insurance company? Is that what you're saying at this
It
point?
would, yeah, I mean, we don't really communicate in that way with other payers, you know, whether they're out of state or across the country, whatever. It's just, there's no process in place for us to know if somebody truly had a trial of a drug. And so, you know, we rely on provider medical records and notes and pharmacy records to do that. So we wouldn't have the information from another plan in that respect.
Thank you. Right?
I'm curious, like, why the provider and patient don't make this decision why does the insurance company make it?
If the provider has the information, we certainly accept it. So if they have, you know, Mrs. Jones was already tried in this medicine and, you know, we get sufficient information, that's perfectly fine. It's just that that's not always available. And if they're a new member and let's say they're coming in from out of state and it's a new provider, we just don't have access to that information. And we don't think like the member self-reporting is always reliable.
Okay. All right, let's keep moving.
All right, page 3, lines 14 to 17 is where it asks to grant an exception to protocols if the insured is stable on a prescription drug selected by the healthcare professional. And the point I would like to make here is that most drugs can be switched without patient harm or adverse effect or really any implication. And there are some drugs that should not be. And that's kind of the purpose of a prior authorization, is to determine, you know, what's clinically appropriate. But, you know, a lot of drugs can be switched, and that happens all the time with formulary changes and such. So we would like to be able to be allowed to continue to do that when it is clinically appropriate. The other point I want to make about this is the way it's worded. It does allow manufacturers to use patient assistance programs and patient assistance programs. And by doing that, it's a way to, you know, manufacturers try to get patients on their drugs, of course, so they're offering assistance to them. And then patients essentially get stabilized on that drug. And if they're considered stable, then this would prohibit us from doing anything about that, and essentially kind of circumvents the prior authorization process. So it would prohibit us from moving that member to a clinically appropriate but lower net cost drug. We've actually seen this happen in our plan. I'll give you an example. There's a drug called, I'm sure you've probably heard of the new weight loss drugs. There's a drug called Mounjaro, which is used for type 2 diabetes. And the manufacturer was offering coupon or assistance programs to members. And then we had, when the new drug, there's a drug that is the same as Mounjaro, it's called Zepbound, and it's for weight loss. So there's same drug, 2 different indications, 2 different brand names. So when Zepbound came out, because it is technically the same drug, we had physicians requesting Zepbound and saying that members were stabilized on Mounjaro. And so that's a way of, kind of a manufacturer technique, I guess you would say, to get members on the drug and then get them stabilized so that they can't be switched to a different drug.
So Nancy.
I know I said a
can you-
lot there.
Yeah, so I have a couple questions. Can you, for the last part that you just talked about with the patient assistance programs, can you tell me exactly where the language is that allows that?
It's this line above where it says the insured is stable on a drug. So you can be stabilized on a drug that the payer never gets a claim for, right? If somebody else is paying the bill. So I'm saying that if we can't, if we want someone to step through a preferred drug before they get to a non-preferred drug, we don't want just the fact that the patient's stable on the medication shouldn't be the only reason why they need to stay on that medication. Because one, most meds can be switched. And two, this kind of has this other implication with assistance programs to make somebody stable on a drug.
So I'm curious, if someone's stable, let's say I'm taking a drug, let's say I'm taking Humira, and let's say I'm taking a migraine medicine. There's a zillion out there, right? Let's say I'm taking migraine medicine number 1, and I'm stable and I've been on it for a year. What would cause an insurance? Does this happen? Could it be that I go to fulfill my prescription and the pharmacy says, oh, you're not covered anymore? The insurance company wants you to switch to this. Is that?
That could happen.
If we remove this, could that happen? And does that happen today?
So it could happen. A lot of times the way it's structured is by tiering. So a preferred drug would be, say, a tier 2, and a non-preferred drug would be a tier 3, and there wouldn't necessarily be a step. There would just be a higher cost share if it was a non-preferred drug. But in some cases we would like members to take the lower cost drug, and so we would ask whether or not they have tried another drug before they get to that drug. So in the case of the migraine drug, you might be asked, if you have ever tried, I'm trying to think of somewhere I have an example of this. Like, let's say you're on, Nurtec for migraine.
Okay.
And our preferred drug is Aimovig. We would want you, and there's several preferred products. We happen to have several preferred migraine drugs on the formulary. But if you were on one that was non-preferred, then we would certainly want you to try one of the preferred ones before, or at least have your provider let us know if you have tried one of those in the past. So if you said, oh yeah, I tried Aimovig, it didn't work for me, and your provider's like, yep, she tried it, then that's fine. That's part of what step therapy is. But if it's never been tried and it's far less expensive, then we would want you to try it.
Hold on, Alyssa?
Could we add language? I think I kind of get where you're going, particularly with like the patient assistance programs. Can we tweak language somehow so that the intent is if insured is stable on a prescription drug that has either previously been approved by the insurance and is now just being changed? Because what we're trying to get at is you can't go flipping people around because you change your formulary. That's where we're trying to go with this. So what language can you offer that
Yeah, I mean,
circumnavigate your patient assistant programs to get through a PA.
Right.
Yeah.
So we don't make those changes very often. So it's not like, every couple of months we're flipping people back and forth. These
But every
changes,
couple of years.
yeah, these changes happen maybe once a year, typically, I would say, or more once a year. And they're only done when there's a significant cost saving to the plan. So it's not like it's willy-nilly and, there has to be a good reason why there is a step in place. Not every drug we don't have a ton of steps in place. It's only when it's very important. So, in those cases, however, once a year, it's possible that we would ask somebody to try, or if they have tried another drug that is preferred. I don't know, if you take away the ability for us to do that, then it does increase, it affects our rebates, first of all, because we can't switch members to the preferred drug, which is the lowest net cost drug. So we can't do that. And if we can't do that, then we're losing out on the rebates, which then drives the overall cost of drugs much higher. So, that's the downside for us. I understand what your concern is. I would say we try to be very clinically responsible about those decisions. They're not made lightly or without good reason, but we do it because this is one of the very important tools we have to control the net cost of medication.
Theoretically, if a drug that somebody has been stable on for years, all of a sudden goes to like tier 3 in your formulary, their cost share is going to go up. Couldn't you, as the insurance or PBM or whoever's managing this, can't you then send to the patient, the insured, something that says your drug has now been switched to a non-preferred, you are going to pay more for it. If you'd like to save more, we recommend these drugs. Then you're leaving it up to the insured whether or not they're willing to do that. But you're not cutting them off from a medication.
So I would say the majority of the time when we make formulary changes, we do exactly what you said. It's the minority of drugs that we apply step therapy to. The majority go from one tier to another. And whenever there's a negative tier, we call it negative tier. If it goes up and there's an additional cost share for the member, that's considered a negative tiering. And where, of course, we do notice members and providers when those changes happen, and we let them know that their drug is now non-preferred, but it's their choice at that point, whether they want to move to a different drug. So that would be a drug that's not prior auth or step therapied.
Okay, so I'm going to ask, because I want to make sure we get to another witness. I'm going to ask people to
I
write
have a
down.
question again too.
I'm going to ask everyone to write down their questions. I promise we will come back. Please write down your questions. I want to make sure we get to Anna. Okay, so you're saying you want this removed, Nancy?
Yes.
Okay. All right, next one.
The next one has to do with it's line 18 to 21, and it just says a step therapy protocol or drug required under the protocol is not in the patient's best interest because it will pose a barrier to adherence or worsen a comorbid condition. The point here is just that that's exactly what the purpose of the PA is. In other words, if a provider, if it is clinically justifiable because of these reasons, then the PA would be approved. So I don't want to remove the ability to do the review. But of course, if there is a barrier to adherence or if there is a likely worsening of a condition, then that's clinically justifiable and would be approved under the PA. So what I'm trying to say is I don't want to remove the step therapy or the PA for that matter. That's kind of the purpose of it, is to determine what is clinically appropriate and what is necessary versus what is not necessary.
Okay, so you're asking that we remove this section as well? Yes.
And I think that's the end, yes, because I had prior auths next.
Okay, so Nancy, can you stay with us?
Yes, of course.
Okay, what I'd like to do is switch to Anne. So we can hear from a provider perspective what this all means. And then we'll open it up to questions as we have time. I promise we'll come back to it. Hi, Anne, welcome. If you can introduce yourself for the committee, and then I think you did send prepared testimony, which we have on the webpage. So that's great.
Great. So, well, first, thank you so much for allowing me to come today and allowing me to attend this committee meeting virtually. I was in clinic just a bit earlier, and so I've stepped out for that.
We appreciate you taking the time.
Yeah. So today I'm speaking on behalf of myself as a clinician, a family physician, on behalf of the Vermont Academy of Family Physicians and the Vermont Medical Society. I am not speaking as a position of my employer, just for disclosure there. And so I am a family medicine physician at UVM Medical Center, Family Medicine in Milton. This is one of the largest primary care offices in the state of Vermont. We see about 27,000 visits over the course of the year. Our staff are answering about 5,000 telephone calls a month. We're situated in Milton, so we are the upper border of Chittenden County, and then we also are seeing patients from Grand Isle and Franklin County on a pretty regular basis. And really, in a time when most primary care practices are closed to new patient visits, we are trying to stay open to, get as many people into the primary care they so desperately need. We had over 300 people on our wait list at one point. So just to give you a little context of primary care up in Milton. With that said, I think we can all agree that the healthcare system in Vermont is stressed and stretched, but that writing and obtaining a prescription should not be. Prescription drugs for us are one of many of the bottlenecks that we have in our system, whether it be the outright cost of the medications, the medication availability due to supply chain issues, prior authorization completion, or step therapy. The decision to prescribe and the process of actually picking up and starting the medications can be quite arduous. And I'd like to urge the committee today to reform our step therapy within the state of Vermont protocols, those protocols that we're talking about. So this time of year, from a clinician's perspective, is a great time to be talking about prior authorizations and step therapy because it's January and all of our patients are potentially on new insurance plans. Their formularies have changed, as we just heard from Nancy, and everyone is starting at a zero sum in terms of meeting their deductibles. This means that every time I order or reorder for those with chronic care conditions, a medication, the insurance companies have the opportunity to deny my request based on PAs or step therapy protocols. And every insurance company has different rules. And these rules, as far as I can tell, are based solely on finances and the deals that have been brokered between insurance companies and pharmaceutical companies, rather than having true evidence-based logic behind them. From the patient perspective, this can absolutely lead to delays in care. And delays in care can start with patients not even bothering to pick up the medications because they have to return to the pharmacy multiple times to figure out if their prescription has been approved and if it's been approved in a way that they can afford it. I think it can delay care and lead to worsening or uncontrolled health conditions for sure. And so I'm going to use one example, and this is, I think, these are both primary care examples that I'm going to talk about today, and they may apply more to the non-specialty drugs as you were just hearing about. But this is an example of Michael. Michael was a 3-year-old child with asthma. Come fall, like many of us know, the first colds start to go around and Michael's asthma tends to worsen. He goes from needing just an albuterol inhaler, one of the most commonly prescribed inhalers for asthma and COPD, to needing controller medications. Controller medications are often a combination of two different drugs that are long acting, so that you have to take them only once or twice a day. They can help to reduce airway inflammation, and they relax the airway muscles to improve breathing. They're notorious for either not being covered by insurances at all or by requiring lengthy step therapy protocols. Over the course of 2 months, Michael's mom, a mother of 4, all under the age of 8, I think at this point, made 3 different trips to the pharmacy, had 6 to 7 phone calls to her doctor's office, had 3 personal calls to the insurance company, and her physician wrote several letters of support to the insurance company trying to get this medication approved for him. It was Symbicort, so a common med. In the end, his insurance company would only approve the brand name of the medication, not the generic, which had logically been prescribed. This family was on Blue Cross Blue Shield via the Vermont Health Exchange. During this incredibly stressful time, the family had to ration the medication, so they were giving him once daily dosing instead of twice daily dosing. And they didn't have the extra inhaler needed to be able to send into the school, right? Because you're required to have inhalers in the school for their emergency action plans. Now in 2024, they're now on Cigna via the healthcare exchange, because as you said, these often, switch every year based on benefits and cost. And the first refill of this year had to be for generic Symbicort, and it required another in-person visit to the pharmacy to get filled. In this story, I specifically mentioned inhalers used to treat asthma and COPD because these are conditions that, when poorly controlled or untreated, are among the most likely to end in ER visits or hospitalizations, because they often require specialized breathing treatments or oxygen as part of their therapy, things not at home and not in many doctor's offices. Did you know that just a bed overnight in a hospital is close to $4,000, or at least it was a couple years ago? So you're already in the thousands. And yet albuterol, and a generic drug, is one of the most commonly prescribed and effective, and has become the victim of step therapy. So in the case of albuterol, I may order it as albuterol, the generic name, can often be found on the $4 prescription list at large corporate pharmacies such as Walmart or Walgreens. But now when I order albuterol, there's a 50% chance, and admittedly, that's probably a little bit of an embellishment, but still, that it'll get returned to me with a denial, and the denial will say something such as, you must order an alternative to albuterol, such as albuterol. It doesn't seem to matter if I use my EHR to help me predict which albuterol will be covered. It doesn't matter if I write okay to substitute on my prescription. I still have to spend the time going back to the patient's chart, figuring out which albuterol I ordered, potentially addend my note to make sure I've provided enough information to the insurance company, and communicate back to my nursing team and my patients that I have to order a new medication. And my only recourse, truthfully, other than talking to you guys today, is that I can forcibly file the notification into my shred bin. In this case, as the provider, I can truly say that step therapies are increasing my administrative burden and are affecting my sense of well-being and burnout due to the absolutely ridiculousness of that situation. It's a generic drug. And I have one more example I'd like to discuss, and I purposely stayed away from talking about obesity medications, but we will talk about GLP-1s today. And so I'm going to use that as it applies to diabetes. I think you guys know that diabetes is one of the leading causes of disease, morbidity, and mortality throughout the United States. Medical costs and lost work and wages of people diagnosed with diabetes is up to $431 billion a year. And medical costs for people with diabetes are more than twice as high as people who don't have diabetes. So that is national data from the CDC. I apologize that I didn't have Vermont specific data. But all the same concerns for me about patients being lost to treatment, having delays in treatment, condition destabilization, and physician administrative burden and burnout all still apply. But I'd also like to add the sense of the loss of physician autonomy and my ability to best apply best practice and evidence-based care in these cases. The realm of diabetes drugs has been revolutionized in the last decade. The new drug classes, the SGLT2s and the GLP-1 inhibitors, you might have heard of them as Farxiga or dapagliflozin, or Ozempic, which is semaglutide, which is in the same class of the Mounjaro we were talking about, have completely changed the way the American Diabetes Association, so the ADA, guidelines tell us to approach diabetes. These drugs are touted because they improve health outcomes. They reduce the morbidity and mortality, and they reduce blood sugars. They help to protect heart and kidneys, and they also cause weight loss. That is a huge benefit to these drugs. The problem is they're still under patent, and therefore they're brand name and expensive. They're going to be tier 3 drugs at least for many insurance patients. And they've quickly put step therapy protocols in place that dictate that I use older generic drugs like metformin or sulfonylureas, whose side effects can include GI side effects such as chronic diarrhea, low blood sugars, and weight gain. So can potentially worsen someone's diabetes by making them gain weight or worsen their sleep apnea or their high blood pressure or things like that. So the example I use here is George. He was a 37-year-old male. He has been coming to see me for a couple years because he was worried about his risk of diabetes and heart attack. About 2 years ago, his father, who had diabetes, had a massive heart attack. And his father died in a relatively traumatic way in the hospital. And this clearly affected George in a negative way. And so he'd been very worried about developing diabetes. So last year, as in his appointment, his A1C was in the pre-diabetic range. And this year, he's now solidly diabetic. His A1C is 7.4. He also has a BMI of 38. George's wife, who's on the same insurance plan that he is on, is also diabetic, and it is on Trulicity, one of those GLP-1 A drugs. She tolerates it well and has no problems with the weekly injections and has lost weight. So he's pretty jazzed about potentially starting this drug to protect him from diabetes and all the other complications. But almost immediately, we get denied for this drug for him because he must try and fail the other diabetes classes of drugs before I can prescribe the medication that is the best evidence to support his use. And I attached here the ADA guidelines from 2023, and I think this is also might be the 2024 one, which really shows that that the recommendations are moving to using these new drugs as first-line therapy based on patients' other chronic conditions. And so, just questions to ask is what happens to George in the process of trying and failing these other medications? He has the ability to gain more weight. His blood pressure can go up, those other kinds of things. And it really does prevent, after me having several conversations with him about what might be the best drug, and he's ready to start the drug at that visit. That's my opportunity to start that drug. I can lose my momentum for care, when I have to go through back and forths of telephone calls and emails and MyChart messages trying to get these drugs approved. So in summary, I think Section 1 does not eliminate step therapy, but it creates a pathway for common sense exemptions to be requested by a patient or a healthcare professional. For example, if the patient is already stable on a prescription drug or step therapy, would most likely worsen the comorbid condition. I agree with that. I think there's truth in that. The language has been modeled off legislation already passed in both Massachusetts and New York that included nearly identical lists for clear exceptions to step therapy protocols. And our neighboring states have done this, and it will greatly improve the care for our patients and reduce the burden on myself and other healthcare professionals. So I hope that we can continue forward with this section.
Great, Anne, thank you for that. Do you have time for a couple of questions?
Sure.
I'm gonna say, Daisy and Mari, if you have questions, put up your hands. I'm watching, but I'm gonna start with Brian.
And so this is a question for providers and payers, so anyone could answer.
Okay.
But I've heard that, a change in formulary or a change in insurance provider, or maybe like a change in plan type even, I'm not sure. These changes could cause the payer to ask the patient and the provider to try something new simply for the reason of cost, as long as there's no clear comorbid condition or it sounds like medical condition or medical implication. But like, I haven't heard anyone talk about the psychosocial or emotional impact. Actually, that's not true. The provider did, because you talked about the cost, I think, and that's social. But I mean, but then there's more to that, the emotional impact and how that will then affect the underlying condition or trigger new conditions. So I'm curious if either payer or provider would want to reflect on how those factors are considered when making these decisions.
Well, certainly I can talk about it, especially from the diabetes drugs. You're often targeting many conditions when you choose a drug. So, with so many of our patients who have diabetes also are overweight or obese, or they have kidney disease, or they have heart disease, or have a high-risk family history of heart disease. When they get on a GLP-1 and they start having success in terms of losing weight, when they've tried, most of our patients have tried weight loss in many ways for years and years. To then have to go off of that is very demoralizing. And I would also say that when you tell a patient, our patients, especially our Medicare patients, but not just our Medicare patients, our patients who are in the middle, our middle class patients who have families who are budgeting very closely for all of their expenses. If you say, well, the drug that you've been on for 2 years now has a cost differential and you can stay on it, but it's going to be an extra $100 a month for you, that's not a choice that they get to make. I have to come up with a different solution for them because they don't have that extra $100 or more a month. And I also would like to say that about the migraine drugs. Many of these drugs, and to be clear, I'm not prescribing Nurtec and some of these drugs all the time. They're more in the specialty range, but some of these patients have been chronically debilitated, which leads to loss of work, loss of revenue, loss of all of those things. That to then say they finally have a drug that works, that they no longer have access to, absolutely, it has a big psychosocial impact.
I want to thank you, and I'm gonna let Nancy, you popped on, I want to let you answer that question as well, if you want to.
Yeah, I guess I just want to say that a lot of these factors are considered during the process of a step therapy or prior authorization. So collecting that information to know that a member, speaking like to the migraine example, if they are having great success with this medication and after many years of trying different drugs and they finally landed on this, that would likely be a very good reason why they would not be forced to do a step. So I think it's very dependent on the clinical situation of the member. We try not to be unreasonable in those clinical decisions. Like I said before, if they have tried other drugs without success, then that's certainly justifiable. So.
Thank you. Mari, do you have a question?
I was just going along with what Alyssa was saying about cost sharing. With a platinum plan on the exchange with Blue Cross Blue Shield, Zepbound, the newest GLP medication, even with a manufacturer rebate, the co-pay, the cost share out of pocket, not including the deductible and all that, is $362 a month. So I support that. Insurance companies already have a tool to limit access by the sharing. So it's making it unlikely that most people would be able to use that medication. And even the other medications in the same class on that particular plan are about the same out-of-pocket cost.
Okay, thanks, Mari. Leslie?
Listen, one comment, if I may. On Dr. Hogan, Nancy, your second slide, the drug distribution system, and it's, up in the right-hand corner. And it seems like what I'm understanding is the only way that you can leverage reducing your cost is by limiting access to members for drugs. Is that unfair? Or that's what it seems like, that there's really no other levers that you have to protect your own economics?
I would rephrase that. I would say we want to assure that the medications that people are on or are want to start, that medication is not only clinically appropriate, but also we have an opportunity to get that member on a drug that has the lowest net cost. So we're not trying to do things that are clinically inappropriate or prevent access to members. We're simply trying to assure that the medication that they're on is the lowest possible cost, but also clinically appropriate.
Okay. So, what you're thinking is that what you know about the patient and the clinical appropriateness for that patient outweighs what their own clinician knows about the patient?
No, not at all. I'm saying that the prior author.
Nancy, we lost you don't look like, there you go. Now we can hear you. Go ahead. Can you start over?
I'm sorry. I said, no, not at all. That's not at all the case. We are just asking for information at the time of prescribing to support that clinical appropriateness. That's what a prior auth does, right? So we're talking to the provider at that point.
Right, so you're asking the provider to justify their decision-making in order to pay for it, is what I'm hearing. Well, anyway, that's the point that I'm worried about, I guess. I'll say that. More than worried, actually, upset. Go beyond worried.
So, okay, it's, I think we have more to talk about here, so we'll chat as a committee what we need. I thank you both. This is, a difficult one to understand anyway, and then, it's been a long day. So thank you both very much. We will be back in touch and, figure out what we need to do next. So,
Thank you very much.
Yeah. Thank you. Thank you, Anne, very much for taking the time. Before we wrap up, questions, comments? Pepper?
How does this all relate to the process that I experience when I go to the drugstore to get a drug? I end up getting the generic drug for whatever it is automatically because we pass along.
Yes.
So how does this whole relate to that?
That's a good question that we'll have to ask. I can have Nancy come back. But we are not pharmacists.
No,
Okay, so let's
as
just
a prescriber, there is a section that says generic substitution permitted. So if you sign that, if your provider signed on that side, then they will.
But I think you're saying like how does that all play into whether or not we're asked to do a different drug or something? We have to understand the step there a little bit more.
Can I throw out there for anybody who's listening? the difference between specialty drug and non-specialty drug, we talked about this last year, I remember with PBMs, and there was this squishy definition. Can somebody come back to us? It's just a question, you don't have to answer it now. Can somebody come back to us? What defines a specialty drug? Is it standardized? Does everybody consider everything the same as a specialty drug? So, because I'm thinking about some things, so if somebody can come back to us with that.
If not, we can have to do it when we have to take this.
I'll say no.
Melanie?
And just to Leslie's point about the slide, whatever, too, with the map of everything. And I understand we need to look at cost and all of that. There's only one line that goes to the patient and 4 that go to the PBM. So I know that we're going there, but I'm just like, we can't make that the only.
There was also no line that goes to the provider.
Exactly. So I just, looking at that.
And that, yes, that's a bigger issue.
I know, so I'm glad we're looking at it.
Then, yes, and that, we will talk about that with the PBM bill. Okay, so I think we're done for the day, and we are back here at 9 a.m. for mental health advocacy morning, and then to talk to the DAs. We heard from DMH about the programs that we've all put into